I'll be hosting the second part of the session today, and I hope everybody has the agenda. And as you know, I'm hosting the symposium, and I've been doing this for 11 years, and this is the 11th year. And I'm going to focus on actually real-world data, and I'm grateful to iPro to have shared some of this data, which will come a little bit later on. But I want to set the stage for why this theme was so important today. So objectives of the symposium, particularly my talk, is what can we do to increase treatment of patients in their own home, which in our case being dialysis, but I think all medical care, really should originate from home. And what strategies can we do to retain patients if the kidneys fail to continue dialysis at home? But of course, the best thing is a transplant, and we have a little bit of transplant data. So first of all, Brooklyn is one of the oldest boroughs, and it has a large heterogeneous population. As you can see, it's divided into so many areas, and one really has to be living in Brooklyn to know Brooklyn, I think. It's so vast. But also iPro that I've partnered with now for so long, it's almost a decade, I think, or longer. It serves 62 counties within New York state. It should be state. And so there are a total of 82 counties, and I hope my statistics are still correct. And there's the land population to dense. It's very dense. A lot of people living in the city. About 419 per square mile. Population of New York City grew more than 4.4% actually, and actually transiently declined, but has regrown. And more than 8.5 million reside just within this few boroughs. So everybody knows this. It was mentioned in the previous talks. This was the key picture, and National Kidney Foundation, I want to thank. I borrowed this picture from them. Showing President Trump signing the Advancing American Kidney Health Initiative, and just keep this date in mind, 2019. Standing here are a lot of members, but also one of the patient representatives. And this is his signature smile, which you've seen a lot on the television, and also him signing executive orders. But this was in 2019, and this is a picture from CNN. So the mission of Advancing American for Kidney Health Initiative, it's an initiative, just like my hope is to have an initiative of no kidney disease at all, is to increase focus on home dialysis and transplants. And what the administration then had proposed that 80% of new patients whose kidneys are failing by 2025 should be receiving home dialysis or transplant. And you'll see whether this is really true. That's why I partnered with iPro to get what's really happening in more than five network regions. And, along with the initiative, Medicare said the only way to do this is to give physicians or providers an incentive. And it's called the ETC model, which is, which I will talk about a little bit, where CMS front loads financial support to incentivize home dialysis and transplant to those organizations that have changed their mission in that direction and that can show that you can bring more patients in hemodialysis. So this is a data analysis I had done, but this data is 2017. So in order for me to figure out what has really changed, I had to go back in time a little bit. So you can see that, about 87.8% were going on hemo, about 9.5% were going in PD, and a dismal 2.4% were getting sort of transplanted, preemptive transplants, right? And so then I looked at USRDS data. Now, just so that audience understands, the USRDS data lags by 3 years, all right? So this is why we need a separate source of data from iPro to get the most current data, because they get the data every quarter. So USRDS data had already shown that the incident of patients whose kidneys are failing had begun to decline. If you can see, it was almost 475, so about 100 cases per million over, let's say, about 2 decades, right? Something we were doing or something, the whole country was doing that's changing this. So why is the rate of ESRD declining? Well, one of the things is that, Medicare had put in an administrative hurdle to fill out a form to justify why dialysis is needed. And to this day, iPro keeps harassing me. How come these providers are not filling this form out? They're late in submission, et cetera, et cetera. They know this. So we are always harassing all the providers across the country. You've got to do this within a certain deadline date. Second, there were enough studies. Ideal study was one published in New England Journal that showed that if you delay dialysis initiation, it didn't matter in terms of outcomes until the patient really has symptoms of uremia. And the third was, which we have noticed, and I'm not going to show this data, that nephrology referral began earlier and earlier as time was passing. And there is USRDS reports, there is other reports also. Thus, nephrologists getting involved early enough to prevent CKD progression. And the fourth thing that we realized why this was happening was because blood pressure and hemoglobin A1C control were the key determinants. And there were like 4 large studies, which I quote here, DCCT, UKPDS, Accord, Sprint. I'm not going to go over that, but those were the large themes that was changing the population dynamics. But then, since I had to nail down as to why is there in-center hemodialysis, and now you see the data from Medicare clearly showing that there's been a 10% decline in patients going in-center hemodialysis, okay? So there is a trend. What about home peritoneal dialysis? Remember, we started with very dismal statistics, 6% or some 7%, and we have now USRDS is showing that it has gone up to about 12%, which is only 6%. Remember that the initiative was 80%, all right? So what about home hemo? It fluctuated somewhat. I think technologies were coming out and old technologies were going, and one of the speakers is going to speak on home therapies, Dr. Gupta. But it has not seen a rise as much as PD, only 2%, right? And I guess she will touch upon as to why this might be happening. And then preemptive transplant, which should be the best choice, it is even quite bad, right? Only 2%. So this was USRDS data. What is the iPro data or, from dialysis facility reports? If anybody wants to spend the time doing data, which is a boring job sometimes, is to, but you have access to this dialysis facility reports, by the way. But it is tedious to tease it out and put it in this manner to show, and Network 2, New York, you can see right at the bottom. It's still stuck at about 6.57%. It hasn't. Which states are doing well? Well, rural states are doing quite well. Arkansas, Oregon. You can see their statistics is quite good, about 16%, but still not what we had hoped for. And if you look at globally, blue indicates patients that went on in-center dialysis. Brown indicates, pale brown indicates those on peritoneal dialysis, and the light yellow ones indicate home dialysis. So United States ranks 25th in PD, Hong Kong and Mexico rank the highest in home therapies, and actually New Zealand ranks the highest in home hemodialysis. So what was the incentive and how much was the incentive? Maybe the incentive is not good enough, right? So it turns out that, on an average, hemodialysis costs $82,000. There's a little bit older statistics with current inflation rate, and you can plug in the numbers and see. It sort of hovers around in that range. PD costs about $68,000, and a transplant, tremendous cost saving, $38,000. So let's see whether this policy that was put in, so in 2008, there was already an upward swing of people tending to go on home therapy. So the nephrology community learned way ahead of time. This in-center hemo, it's too much for patients, and so there was a change already prior to the policy initiative. And so incentives came a little bit later. Maybe data was being collected by CMS, but one of the things the incentives gave was that Medicare doesn't pay until 90 days the first paycheck that comes in, apparently, right? So 90 days, you have to have resources to cover on your own. But so Medicare eliminated that if you can show that you can drive patients towards home dialysis. And the other thing it did was it paid upfront 50% more for training, nursing, and infrastructure for training costs. Home hemo also took off a little bit, but not as much as PD. Okay, so the time frame of takeoff is around 2007, 2008. It helped home hemo grew, but the real takeoff happened when the technology of better and easier machine able to do that, which I'm not allowed to take the names here, so help patients adapt to those technologies. So what about the patients who were not new but already on dialysis, the reverse, which was shown by some of the speakers, and that they were able to translate, put PD and restart home hemo? New York, prevalence is only 4 it's very, very poor still, right? So prevalent patients don't tend to go on home as much as you would like. And Brooklyn, was on 1.8%. So this is not good still, right? And so then I started wondering, what is the reason this could be? Is the number of facilities and nephrologists ratio. Maybe there's not enough doctors who are trained. Maybe there's not enough. And so New York, on an average, so in the next slide, I'll show you how many facilities exist in this country. As was mentioned by Dr. Bailey, there are more dialysis centers being created than preventive models to prevent this, right? So there's tremendous amount of growth of dialysis centers, and New York has, on an average, 148 patients per facility, average, okay? And South Dakota, on the top, has, 55 patients per facility. It's, there's certainly more facilities per patient population in South Dakota. So New York, average New York nephrologist has to take care of over 100 dialysis patients and on an average 1,000 CKD patients. So if somebody wants to know how many facilities exist, 8,150 facilities exist in this country. But look how many offer home dialysis, only half, okay? The one in the red, they're certified, but they don't have any patients, right? So really, 50% of 8,000, only those offer. And if you look across the board, who are the ones that are getting dialysis and are stuck in center and who is African Americans? 3.1-fold higher incidence rates. Okay, I circled back to Brooklyn again. So New York City has a tremendously heterogeneous population, and Brooklyn has about 23.1% African American, and which was mentioned by Dr. Bailey also, Bed-Stuyvesant is the area, and there is Dr. Brown in the background who spent his life in Brooklyn, and he can comment upon this. Am I correct with this data still or not? But there's another population that has expanded, and that's the Hispanic and Latino population. That contributes, shown here in New York, 30% now. And the whole pyramid has expanded, right? Apart from obesity, every age group has expanded over time. So one has to wonder, where are we going to get these resources to take care of all of this? And looking directly at African American population that has 3.4 or 4-fold higher, the intake by African American community to home therapies is actually much, much less than Caucasian population. Shown in red is this continuous cycling PD therapy. Shown in the blue is continuous ambulatory dialysis, and shown in green is the home hemo. So there is cultural issue also, right? And so then I divided it into, if there are 8,000 centers, 50% are this, why isn't it happening? So I did this in a different way, as you can see, And what turns out is that 90% of the patients that are on home therapies actually belong to for-profit. So not-for-profit like ours also, only less than 10% of patients are on home therapies. So there is having some resources to have this modality is very much essential. Otherwise, we are not going to succeed. Now, CMS put in a new metric. It's called actual to expected switch ratio. So those who were, expected to go on home, but did not go on home, but they went on in-center. So the way to interpret this is that, okay, if you have a ratio of 1, meaning it was good, like you did not show any weight that your patients were going on home. If you have above 1, 1.2, 1.4, 1.5, that means, okay, more and more patients are going on home. So I like this metric a little bit. So turns out, if you divide it by facilities, only 186 facilities did well to be able to switch patients to PD from in-center hemo. Okay, so the 4 is phenomenal. Oops, let me go back. 4 is phenomenal, right? There are very few centers that are 4 times their expected. So how do you calculate expected? Expected is calculated from 3 years prior. I think I'm correct. Some iPro people may correct me. Is 3 years prior, what was your rate of home intake? They take that as a baseline, and then they do it going forward, right? So in 90% of the facilities, when it's 1.05 being the cutoff, they don't switch, right? So you cannot win this statistic. Standardized modality switch ratio, there are very few handful of the facilities that are able to do that. And we heard from some speakers what drives selection of patients, the infrastructure, resources, etc. So questions from this analysis, which I'm giving, which came to my thought, but maybe I'll take later on in the panel discussion, is patients prefer to get, maybe they prefer to still like to go 3 times a week rather than doing daily dialysis. It's too much on them. If you ask somebody, you're going to have a doctor's appointment 7 days a week, or you want it once a day, once a week, or you want it once in 3 weeks, everybody will say, once in 3 weeks, that's enough, traveling, going to a doctor, and I'm scared to, right? That may be going on, apart from all the socialization issues that people have talked about. But I think that's the biggest driver. Coming to 3 times a week is better than coming 7 times, Facilities do not have resources to do home therapies. And is it that home dialysis is not profitable, so they're not going to do it? So what should we do collectively to help grow? And these are some of the things that I have some information or data on some of them. So perhaps we should not be giving, and CMS is here, right, representatives, to open in-centers anymore. Just give licenses to open home dialysis centers. So this is to take a legislative action, right? Or number 2, open PDs. Now this was controversial because there were some speakers who were saying they can do everything as outpatient, right? I don't think it's going to work too much with outpatient because the overhead costs and also that you may have to open a PD unit in a hospital. That's where they're crashing into, right? Grow home training programs, but mainly to drive training of nurses if you want to bring that patient home eventually, right? And there's tremendous shortage of home-trained nurses. And then increase the salary for home-trained nurses and offer nephrology trainings with home therapies, and we have representatives who are offering those opportunities. But one of the things that I found might really help is having multilingual Hispanic Black task force to help educate these patients. Now this is thanks to Svetlana, who's in the audience, who provided this data, and it was a tour de force to get this data aligned, and these are 5 networks: New England, New York, South Atlantic, Ohio, and this is the most current data, right? So if you can see pediatric and adult, how many patients go on home therapies, and these numbers are here. And this won't make sense until I show you in a better representation. So 21,000 patients went more on hemodialysis from that time period. And I also have to thank my biostatistician, Angelica Grusner, who helped me with this data analysis, putting it together. So what I did was transform it and show you that hemodialysis, 2% increase in home dialysis modalities occurred from 2070 to most current 2050. That's only 2%, okay? And then by network, was there some states particular? No, across the board, same. And the most hurtful part was preemptive is the most dismal, which we should be driving more also. And as you can see in the brown, intake of PD was very low. So the other question comes up is, what about patients to PD after home hemo? So if you take prevalent population, what has really happened is that in 1 year, in 2 years, and 3 years, on an average, only, as you can see, less than 5% or 4% will transition to home. They will not go on. Once you put them on in-center, they'll remain on in-center. And then how long can they remain on PD? This was another data analysis done differently. And what percentage remain once they start on PD? And you can already see here the data with adults. So this is what happens in real life. The PD patients do not last more than 3, dramatic decline, and by 5 years, you have barely anyone left. So they don't live longer, whatever, you can debate the reasons, but clearly, thank God if they got transplanted, that would be the best thing, but this is the real data. And in pediatrics, within 1 year, they can only live on PD 1 year they can do, and they're back, look at the statistics, right? So the answer is, are we successful in the initiative that was put in by the current administration, which was the previous administration? The answer is obviously no, we're not being successful, right? So why do patients not want PD? Well, their fear of infection or peritonitis is number one. If you speak to them and do focus groups again and again and again, I'll catch an infection, I'll die, but actually there's data to show that PD has less infection rate and they're worried of dying suddenly at home or doing dialysis. They have tremendous fear, right? And then when you dive a little bit deeper, it turns out they say it's too much to learn, too much. Now, I may be wrong. There are groups here who've been successful. And so I looked at DOPS data, which was Jeffrey Pearl's data, to show if you want to grow PD utilization, you have to work on two things. Not only increase, but also retaining them on PD, right? So if peritonitis was the rate, but see, it's across the countries, and this is a little bit older data, is, averages 0.4, and cutoff by Medicare is around 0.4, right? Per patient per year or whatever. And we are hovering between United States is between 0.3, and so we are not doing bad. If you have to educate patients, look, now that may vary center to center, but on an average nationally. One metric that is clear is that the volume of patients in a center determines patients' retention to PD and preventing peritonitis, right? So how many patients do you need at a minimum per nurse is 16, as shown here. It touches the boundary, but by and large, the driver is just like if you ask a surgeon, you want to go to somebody who's done only 2 gallbladders in their life, or you want to go to someone who's done 50 gallbladders? And this was shown in Blue Cross Blue Shield studies done in the state of Michigan, where a second opinion mattered the most, of that drove individuals to select what surgeon, right? The similar process here. You get used to the dynamic of how PD works and infrastructure moves with it. But the other thing across the countries was there was tremendous heterogeneity in terms of who was getting peritonitis, but also many of the hospitalizations in the United States and affluent countries, as every episode takes a patient to the hospital. The problem is if they take them to the hospital, 20% of them lose the catheter. Once you lose the catheter, it's finished. Your PD is off. So the other thing that I'm almost towards the tail end of my presentation is that what I have noticed is there's tremendous heterogeneity in what patients are told how to take care of the catheters and exit site. Look here. Some people use mupirocin, some people use honey, some people use aminoglycosides. In the United States, they use gentamicin, So there's no standardization, right? So that's a big thing. Why? Because we know randomized controlled trials, whatever, but we have not made any policy what is. Second thing is exit site cleaning strategy. each center you go to interview, and there was an individual from IPRO who left, who does site visits, and people are scared of her, right? So, but this is what she looks at, because there's no standardization. We constantly say must give antifungal prophylaxis when patient peritonitis. Look at the data, okay? Never. UK, 88%, so on and so forth, heterogeneity. There's no standardization. We made a policy here to standardize. You must get antifungal if you have peritonitis, period. Because fungal peritonitis is a death sentence, and the catheter comes out. One of the other things that DOPS taught us is that physician-to-patient ratio in the UK is around 33 patients to a physician. In the United States is 8 patients to 1 physician. So no one can complain to me that, they're very busy. They're not doing PD. And so on and so forth. So the data helps, right? But the other thing that when I wanted to encourage PD here is that we have to have a proper organizational process to make this happen. So if we are going to burden a nurse with a PD patient, we have to determine what sort of sick patients we are burdening him or her with, right? So it's just like giving a resident 3 admissions with 17 medical conditions to monitor, or you need 7 patients with 1 medical condition. Everybody will pick the 1, right? So illness ratio or severity illness of taking care of the patient really matters how much the nurse can do, and you can tailor how many FTE you need. The other thing is every program should have a process in place and a deadline date to achieve some targets, otherwise we'll never make it. So here's an organizational thing where, we had created right here at SUNY Downstate, where we are checking for cognitive change, how much the patient ability to learn, the language, the culture, et cetera, et cetera. And then I don't think the structure is being used and want to revisit it. We had created it, and then COVID came, many things happened. And the teaching materials that the patient has to go. So it's a lot the patient has to go through, right? The other thing is home visits are very essential, which is not happening a lot. They do televisits and all. But really in the home, seeing what the patient does in the home matters a lot about avoiding peritonitis, right? And then the training has to follow. I think you heard from one speaker, within 5 days they're trained, and I think this is the model they're following where, there's a pre-training on day 1, there's day 2 inpatient support, hemodialysis, et cetera, et cetera. So there has to be a structure. And so structure is missing, standardization is missing. So in the end, I feel, home therapies, if we need to increase, is standardizing care. Exit site and peritonitis prevention is key. There should be a standardized training method. It doesn't exist. There's a feeling around. And I think the leadership support to open at least a PD unit so that the transition to home can happen is very important. Not only in-center hemo, but in hospital, but a PD unit committed to doing only, that's where we can capture, because patients when they're sick in the hospital are most receptive. And provide training resources, avoid giving certificate, this is my thing, I'll be attacked, rather than in-center. This is something that CMS may want to work on, right? And increase home dialysis certificate of need approvals. I will end my talk there, and thank you for listening. We'll take questions at the end, if you don't mind. So the next speaker I'd like to invite is Dr. Sonali Gupta. So let me come up, Dr. Gupta. So Dr. Gupta completed her medical training in obstetrics and gynecology. By the way, I did residency in OBGYN also before. At Lady Harding and Maulana Azad Medical College in New Delhi, India, followed by a research year in maternal fetal medicine at the University of Tennessee. Sounds small group. She later completed an internal medicine residency at St. Vincent's Medical Center and a nephrology fellowship at the University of Rochester, and Iowa. Dr. Gupta is Associate Director of Outpatient Nephrology and Associate Program Director of the Nephrology Fellowship at Montefiore Medical Center and Medical Director at Fresenius Home Dialysis Center in the Bronx, New York. She has authored over 35 publications, 3 book chapters, and has presented internationally. A strong advocate for home dialysis, she created a widely used online learning tool for home hemodialysis, earning recognition as a finalist for the ASN Innovation in Medical Education Award in 2022. Congratulations. Her clinical interests include home dialysis, obstetric nephrology, and hypertensive management. Welcome, Dr. Gupta.
Thank you. Thank you, everyone. So today, we'll be talking about home hemodialysis. So as we see that, we are still struggling with getting patients on home hemo. So we'll see, we'll see what's going on, and we'll go over it. So the outline of my talk will include why to choose home hemodialysis, patient selection criteria, individualizing the vascular access, individualizing the home hemodialysis machine options, and then basic home hemodialysis prescription, and we'll go over the learning tool to make it more accessible and how to learn home hemodialysis and home hemodialysis dose stimulator. So why choose home hemodialysis? This is the first question our patients always ask us. So what better place to do dialysis than home? So it doesn't only have health benefits, but it also has lifestyle benefits. One of the major health benefit is on the cardiovascular system. So it has been shown that patients on home hemodialysis, they have better cardiovascular outcomes as compared to in-center. It leads to better control of the hypertension and is associated with less cardiovascular-related hospitalization. Studies have shown that patients who are on home hemodialysis, actually it helps in the regression of left ventricular hypertrophy. It leads to better control of volume status, lower risk of regional wall motion abnormalities, and improved exercise capacity. It has a lot of other benefits on quality of life, which is so important for our patient. It has been associated with better mood, less dietary restrictions for our patients. It is associated with reduction in the frequency of sleep apnea episodes, improvement in the symptoms of restless leg syndromes, and improvement in post-dialysis fatigue, which a lot of our patients suffer from. For the young patients, young women, home hemodialysis is associated with better fertility and improved fetal outcomes. Home hemodialysis, because we are doing more sessions, leads to better control of hyperphosphatemia, and the extended sessions allows liberal diet and give them freedom from a lot of phosphorus binders. So now let's review patient selection criteria. So one of the most important questions we have is who should be offered home hemodialysis? And the answer is actually all our patients. All our patients and caregivers should be offered the education. And then, if they opt for training for home hemodialysis. But education is very important. We need to bring it up to our patients and caregivers whenever we are starting a patient on dialysis. The 3 main pillars of home hemodialysis is it's a trained physician. And one of the recent surveys actually showed that even as physicians, we are not doing that well. A lot of physicians and new start nephrologists, fellows, they are not that confident in starting patients on home hemodialysis. Then we need a motivated patient who is willing to learn how to do it. And then most important is supportive, accessible, and reliable staff. So these are the 3 main pillars that we need for home hemodialysis. So patient characteristics favorable for home hemodialysis, anyone who is physically and cognitively intact, they are able to make their decisions, they should be offered home hemodialysis. Patients with strong support system, if they are unable to perform by themselves. Anyone who's willing and motivated to learn. Lifestyle choices, a working patient, young women with kids, so they should definitely be offered home hemodialysis. And failing peritoneal dialysis, but patient wants to continue home therapy. A patient who has difficulty with ambulation and transportation. Patients with high interdialytic weight gains. Persistent hyperphosphatemia. And anyone who needs frequent dialysis sessions. They should all be offered home dialysis. So now let's review some patients that need further intervention and support before we can offer them home hemodialysis. Patient with unstable housing, they may need social service support before we can offer them home hemo. Unreliable electricity, water, and sewage services, plumbing and engineering work may be required. Patient and partner, they are unable to follow instructions. So this is very challenging, and it requires dedicated redirection and positive reinforcement. Unstable mental and behavior conditions. So we need to wait till the condition improves for patient safety. Patient with active drug and alcohol abuse, they need referral to the addiction medicine and close multidisciplinary workup before we can offer them. So now let's review not ideal candidates for home hemodialysis or where caregiver support is needed. Anyone with uncontrolled seizure, they might not be the right candidate for home hemodialysis. And patients with severe symptomatic intradialytic hypotension, again, for patient safety, they might not be the right candidates. So we have a tool available that helps us in patient selection, and it is called MatchD for home hemodialysis. So this criteria, this can be downloaded from the homehemodialysis.org website, and it gives clear markings in green, where you strongly encourage home hemodialysis, yellow, where further workup is done to eliminate the barriers, and red, where patients might not be the ideal candidate for home hemodialysis. Now, the next important issue is individualizing the vascular access. So we know that we have three main access: arteriovenous fistula, graft, and the tunneled hemodialysis catheter. Fistula, they are the most preferred access. They have the best patency and lower infection rate. Arteriovenous graft, they are done when the veins are too small or not suitable for the fistula. So the problem with graft is they are more prone to thrombosis and infection. And then we have the tunneled hemodialysis catheter, which is the least favored and more prone to thrombosis and infection. The other important thing in home hemodialysis is our patients or the caregiver needs to learn self-cannulation. So we need to provide them adequate hands-on training. We need to train them on fistula assessment. They can use prescription glasses or magnifying glasses to help cannulate. Even the head-mounted lights are, we teach our patients they can use the head-mounted light when they are cannulating their fistula. Cannulation technique is reviewed multiple times by the home team. Buttonhole cannulation is sometimes preferred by the patients because to overcome the fear of cannulation. So throughout the home hemodialysis training, we provide education and support to anyone who has fear of needles. We tell them how to deal with pain during cannulation and how to solve difficulty with cannulation, how to troubleshoot that. What about emergency situations, how to control the bleeding from the vascular access. And we give them education on how to prevent access infection and how to take care of catheters. The next important thing is individualizing the choice of home hemodialysis device. So we have multiple home hemodialysis machines which can be used and tried at home and all does the same purpose, have some advantages or disadvantages. The other important part of home hemodialysis is the water treatment. It's a very important part in planning and training. Plumbing may sometimes need to be adjusted. It needs a home visit and evaluation by home care team. Water system with home hemodialysis machine is often compact and simplified. There are two types of water purification system available. One is the reverse osmosis system, and the other one is deiodinizer system. So this reverse osmosis system can be used with any home hemodialysis machine. Tableau home hemodialysis machine has its own water system in the machine that uses the reverse osmosis. The other one, we have deiodinizer system, and some dialysis machine uses this system. So so as I told you, we have a number of different machines for home hemodialysis. One of them is a big machine. It's similar to the in-center but it's pretty big, it is portable, and it uses the portable reverse osmosis water treatment system. The other one we have is a more compact machine. It has been approved by FDA for nocturnal therapy and even for solo therapy. So that was a great relief for the patients. So this compact machine is easy to set up. It has a disposable cartridge that can be inserted. The connector locks themselves, so there are less chances of accidental disconnect, and we have optimized clamps to prevent the cross-clamping. So for this machine, we have two types of dialysate. Either we can have a pre-mixed dialysate bags that is already formed, or dialysate can be produced using the pure flow dialysate preparation system. So the dialysate bag, which is already pre-mixed, it comes in 5-liter bags. And as we see, we have lactate as the buffer, and it is available in different concentration of potassium and other electrolytes. The dialysate that is prepared using the pure flow SL system produces dialysate in the batch volume of 20 liters and upwards. So, patients can make dialysate in the volume of 20 liters, 25, 30, 40, 50, and 60. And again, we have different potassium concentration, and lactate is used as the buffer. The next machine is Tableau hemodialysis machine. It's also a simple machine. It has a console that has everything inside it, and even the water system is inside, the dialysate is inside, so it's pretty compact. It is also used at some places. So the main components of the home hemodialysis setup consist of a cycler, machine cartridge, dialysate, and an app to connect remotely, where we can see the patient's parameters at the clinic. So now I'll be quickly going over the home hemodialysis prescription. So as a physician, and when I was a fellow, I myself had a lot of difficulty how to make the prescription for home hemodialysis. And sometimes, it comes in our practice, because if we are scared of how to do it without using the app or simulator, then we don't feel confident, counseling our patients to be on home hemodialysis. So I'll go briefly and tell you how simple it is actually. So before we go to the prescription in detail, some things that we need to understand is, while making the prescription, it is very important to understand the patient's value, because we need to understand what does our patient want, how often the patient wants to do dialysis, how long the patient wants to be on dialysis. We need to lower the burden on patient and their care partner. And the ideal prescription actually might change over time, because if the patient, it depends on their work and what they want. And then important thing we need to consider also and keep in mind is the residual kidney function. So some example of prescription that offers flexibility is, we can use incremental prescription, where we increase the frequency of dialysis. We can use 3 times per week, similar to in-center. We can do short daily, and we can also offer nocturnal home hemodialysis. So important concepts before we begin with the prescription is, this home hemodialysis is different from the in-center. Here, the dialysate efficiency approach is used, where the dialysate flow rate is lower than the blood flow rate. As in contrast to the in-center, where we use standard KT over V, for home dialysis, we use per treatment single pool KT over V. And we want to keep the UF goal less than 8 ml per kg per hour, because that is associated with lower mortality risk. And the patient should perform at least 12 hours of dialysis per week. So with keeping these things in mind, we'll start the prescription. So the components of the prescription will consist of frequency of dialysis system, flow fraction, dialysis flow rate or the blood flow rate, dialysis volume, time on each dialysis session, and how much fluid we want to be removed per session. And one of the formula that we will be using is KT over V for urea per treatment is dialysate by plasma urea concentration into dialysate volume divided by the total body weight. So with the frequency of dialysis session, we'll calculate the single pool KT over V. With the flow fraction and blood flow rate, we will calculate the dialysate flow rate and the dialysate saturation of urea. With total body water, we will calculate the dialysate volume and time on dialysis. And the fluid removal will also help us guide the time on dialysis. So first, most important is we need to talk to our patient and ask what works for them. How many times a week is realistic for them to do dialysis? So if they say 7, okay, I'll try. So we are taking the most optimistic patient. So our patient says, okay, I'll try 7 times a week. So as we see in the graph, the standard, taking into account that the standard weekly KT/V is 2. So if our patient wants to do 7 times, then it comes out to a single pool KT/V of 0.4. And similarly, if our patient wants to do 5 times a week, then the single pool KT/V from this graph comes out to be 0.6. The next thing that we need to decide is the flow fraction, and the blood flow rate. So flow fraction is the dialysate flow rate divided by the blood flow rate. And depending upon the flow fraction, we also get the dialysate saturation of urea. The lower the flow fraction is, the higher, the more saturated the dialysate would be from urea. So if we choose the flow fraction to be 50 and blood flow rate 400, then the dialysate flow rate is 200, and the dialysate urea saturation will be 85% or 0.85. The next step is total body volume. So total body volume for female is 0.42 into weight, and for male, 0.5 into weight. So if we have a 100 kg male, then the total body water will be 50 liters. And so the last step is dialysate volume. So fitting it in the formula and putting all our things inside, we find that the dialysate volume is 25 liters. So now the patient can use the pre-filled dialysate bags that come in 5 liters, or they can produce the dialysate using the pure flow system in the bag at least 25 liters. And then calculating the treatment time, it is the dialysate volume divided by the dialysate flow rate. So we are using 25 liters, and the dialysate flow rate is 200, so it comes out to be 2 hours and 5 minutes. So if a patient, so our prescription is ready. If our patient wants to do 7 times a week with the parameters that we decided, it will be 2 hours and 5 minutes. But again, our patients are never, they never commit, or sometimes they say, okay, 7, but this is too much. I want less time. I want more time. So we have a lot of problems. So that's why we created a prescription simulator that I will review. So this is a learning website that we have created. It is called Home Hemodialysis Learning Tool. So this is, I would encourage everyone to go to this website. It has a lot of stuff for all the providers who wants to teach home hemodialysis, learn themselves, and feel more confident putting patients on home hemodialysis. It covers all the aspects of home hemodialysis and also gives you a lot of scenarios and quizzes where you can go over and review it. So in this, we have a home hemodialysis prescription simulator where you can add all the data, and it will give you the prescription itself. So you can change the frequency of home hemodialysis. You can just play with it, increase the dialysate volume. You can see how the weight of the patient makes difference to the prescription, and how we can decrease the time. So by putting in different values, your prescription, you can get your desired prescription. So my main take-home messages are, we should offer all our patients the option of home hemodialysis. And it is very important that we provide the education for home dialysis early on in chronic kidney disease. We need to understand our patients' need, include them in decision-making when we are creating the prescription for them. And we need to empower our patient with the option to choose flexibility as per their schedule. Thank you.
Thank you again. We will move to the next speaker. I'm delighted to bring on board a licensed medical social worker to our group, and that's Marissa, Argentina. Ms. Argentina serves as a patient programs director at the National Kidney Foundation, where she oversees peer support initiatives to enhance outcomes for individuals with kidney disease, living donors, and their care partners. With over a decade of experience in nephrology social work and patient program management, Miss Argentina has been instrumental in modernizing the National Kidney Foundation Peers program, managing corporate partnerships and integrating psychosocial education into patient support services. Previously, she led social work initiatives at DaVita, providing comprehensive support to dialysis patients and training nephrology social workers. Welcome, Marissa.
Well, thank you everyone for having me here today. I really appreciate being here, being able to share a little bit more about empowering our patients through peer mentoring. So I'm going to talk a little bit about our peer mentoring program and why it can be impactful for your patients. So I always like to start off with why peer mentoring. Well, we know that peer mentoring provides social and emotional support. It can increase knowledge, problem-solving skills, self-efficacy, improve health outcomes, and quality of life for patients. We also know that kidney patients face many obstacles when they're diagnosed with kidney disease, when they start dialysis or have to make a decision about starting dialysis, or when they face the long journey towards transplant. And peer mentoring can really help along the way in all of these instances. So NKF Peers has been a signature program of the National Kidney Foundation since 2011, and it has started connecting patients who are living with kidney disease, who are on dialysis, or with a transplant with a trained peer mentor. And in 2015, our program expanded to connecting potential living donors and those who have already donated with living donor peer mentors. And this year, we have expanded our program to support care partners and caregivers of those living with kidney disease on home dialysis, or those who are a parent or a guardian of a child with kidney disease. And today, I'm going to be focusing more on our patient portion of the program. So NKF Peers facilitates those one-on-one peer mentoring connections virtually, either by phone or video chat. Participants can also communicate using our software platform or via text message or email, whatever they prefer. Peer mentors really offer that unique lived experiences that others might not have. Using our software platform, participants can connect conveniently. They can set up meetings between each other. If mentees, though, they're not required to have internet to access the program, and we know sometimes that can be an obstacle for folks. So we are available to help assist by phone and alert mentors so that they should just call their mentees if they do enroll without using the internet. And mentees and mentors are able to decide the cadence of their communication and their relationship. We do have periodic surveys, which I'll talk a little bit more later, that goes out to both members of the pair to request kind of their feedback on the connection and if they'd like to continue or if they do require any further assistance, education, resources that we can connect them with. And we also train our mentors to escalate any issues to us as program administrators so that they're, if they encounter a situation they're not comfortable with or they feel that their mentee could use really additional psychosocial education resources, that we can help do that and not put the burden on the mentors. And we're really able to help follow up with the mentors and make sure that they feel comfortable as well. So we've identified some areas of need when it comes to supporting kidney patients. Often people feel overwhelmed by their initial diagnosis of kidney disease and may not know what to expect for their future. They can feel isolated throughout this process, even if they do have good support systems in place. Many people report feeling this way if their support system does not know firsthand what it's like to have a kidney disease diagnosis. Additionally, as I'm sure you've all have experienced, dialysis can be very overwhelming with our patients. People can become anxious and depressed, especially when beginning their dialysis journeys. For some, hearing that they need dialysis or a transplant can sound like a death sentence for them. And of course, the transplant process can be a long journey, and it is often not intuitive for people as they go through it. And these are all areas where peer mentoring can really provide that additional support. And by sharing those personal experiences, it can give our patients hope. If they see their peer mentor as a role model, if they can see that their mentor can get through it, that they can too. And sometimes that's just something that can't really be replaced by any other type of interaction. And those personal experiences really have a different weight to them. So we take our peer mentor training very seriously, and we want people to feel prepared before they engage with a mentee for a first time. And our training takes place in really two major parts. First, our potential mentors are invited to join our training once they've applied online. We share a link that they can join a self-paced mentor training, which breaks down each of these following topics into short video sessions with quiz questions to assess their learning on each topic. We try to really make it engaging and fun for them, but also that they can take them at their own pace. So if they want to take the whole training all at once, they can. If they'd like to break it up into smaller sections, they can do that and resume wherever they left off. Once they are through all of the training modules, of which I believe there are 12, they are prompted to sign up for a 90-minute live mentor training, which takes place via Zoom. These sessions are typically offered twice a month, alternating Monday, Wednesday, Friday, and Tuesday, Thursday to accommodate for potential dialysis schedules. And during this live training, we really take the time to review the expectations and role of the peer mentor, which includes not giving medical advice and always referring the mentee back to their medical team. And we also engage these mentors in training in scenario-based exercises, which we require everyone to participate in to see how they are really ready to apply the learning that they did in the self-paced portion of the training to a typical mentee call or interaction. And role-playing in that live training are often reported as being really the most helpful in preparing them for engaging with a mentee. And privacy and confidentiality are highly emphasized in these training scenarios. So currently we have 72 active mentors across the country. And the reason I point this out is because we don't necessarily want to focus on matching people based on their location. And I'll get more into about how we match folks in a little bit. But this shows that the variety of experiences spread out across the country and how that network of people really allows us to find the best match for them as possible. I've also had many people ask me, well, how many mentees does a mentor have to have? And we really try to keep that up to the mentor completely. They can set limits in their profile, and we can also assist them with that. And that way, if they're at capacity or they have a medical incident themselves or they just need to take a break, we can adjust that for them too. We also don't dictate how long these relationships need to connect for or how often, but we do provide support for mentors as they're going through their mentoring relationships, should they need help in setting additional boundaries with their mentees or facilitating conversations. But this is also part of the mentor training, but we're there to support mentors as they support others. We don't want them to feel alone through this process. So we do ask our mentees as they're coming into our program really where they are in their kidney journey. So those who identify as patients who come through, we ask them more specifics about their stage of kidney disease. So we really break it down in stage 1 or 2, stage 3, stage 4 or 5, not yet on dialysis. And then we have those who are already on dialysis and those who have transplanted already. So as you can see here, our CKD patients are really over half of those who come through our program. And we are starting to see an uptick in patients who have stage 3 CKD, really identifying that they have kidney disease and want to connect with someone before that. Before that, we were really seeing more folks on stage 5, like I need to start dialysis imminently. So that's kind of a hopeful thing that we can help people slow down the progression of their dialysis, of their kidney disease, hopefully, and connect them sooner for more education about dialysis and transplant. Oftentimes we do hear also that people have come in from pre-dialysis education classes and they're being told that they'll need to start dialysis soon and they want to hear more about getting the dialysis access. What's the surgery going to be like? They want to learn more about home modalities from someone who's currently on them. And then our next largest segment is those who are already on dialysis, and I'll break that down more in the next slide. And our smallest but still significant group of people are those who are already transplanted but might be having a hard time adjusting to their transplant medications or side effects, or those who are being told that their transplant is failing and they might need to start thinking about getting back on dialysis or getting back on the transplant wait list. So historically, when entering our program, mentees on dialysis have overwhelmingly been on in-center hemodialysis, so it definitely reflects a little bit more like what we saw earlier about the folks who are coming in to the different modalities. And there's a lot of potential to reinforce the education about home treatment options for patients who are already starting on in-center hemodialysis. So we know people have to hear information on a variety of ways and multiple times to really consider it an option. And sometimes hearing from the people who are already on the modality or who have been on it in the past can give mentees the space to ask those difficult questions and ask them about what it's really going to be like and maybe try to visualize themselves doing that home modality. So in 2023, for example, about 3/4 of our dialysis mentees were already on in-center hemodialysis, and 1/4 were on some type of home modality, but we're starting to see changes. And last year, we saw a drop in in-center hemodialysis mentees coming through our program, and more all who have already started on PD or home hemo. We know that home dialysis comes with its unique challenges, and having some supports for patients between clinic visits, as well as giving them the chance to ask others how they're getting through those challenges of home dialysis can really be an extra touch for them. So now let's talk a little bit about how mentees and mentors interact and connect. So there are first steps that mentees seeking support go through to get connected with a peer mentor. Firstly, they need to self-identify as someone who is seeking support, whether that be for a new diagnosis, thinking about modality change, wanting to explore treatment as transplant as a treatment option, and that's something that we, that we explore with them in their next step, which is really connecting with us at the National Kidney Foundation. And they can do that one of two ways. They can fill out an online application, which tells us about them. We really have a series of questions, tells what they're looking to connect with a mentor about, or they can call our toll-free number and we can assist them in that process. And our program contact information will be available at the end. Once we have the information that we need, we can really start connecting them with a peer mentor. We can ask them if they want to engage with them on our online platform, where they can, connect via our messaging system. They can schedule calls with each other, depending on how technologically advanced people are feeling. We also have an app that they can use. But if they don't want to, or they just don't have that capability, we can always instruct our mentors just to give them a phone call, and they can always change their mind in the future if they do want to use that technology to connect. So when they're going through the application as a mentee, we ask a number of questions about what do they want to connect with their mentor about, whether that be a particular modality, their cause of kidney disease. We hear people who have PKD and want to talk to another PKD patient, especially if they're having to think about having a nephrectomy. Whether it be, an experience like finding a living donor, what's that going to be like? There might be specific requests, and we do our best to accommodate them, but we can't always guarantee that we have someone with that same experience. So for example, if someone wants to connect with someone who's had a child post-transplant, we wouldn't necessarily know that information about all of our mentors, but we can certainly ask, and that way we can find out if that's a specific need that someone has. And by asking these questions in our online application when we engage with the new mentee by phone, we're able to really make an effective match for them. So going back to that map earlier with where our mentors are, it doesn't have to be the person down the road from you, because if you don't see yourself in that person, that might not make a great match. And making those matches on the mentee's needs and preferences really makes for an ideal matching pair. I always tell people it's a little bit like online dating. You just never know, but we do our best. Sometimes you have to change the parameters. So again, really thinking about if you're a mentee wanting to talk to another woman who's been on PD, we could easily do that. That is something we can filter for based on the questions that we ask. So we could accommodate that request. So we've also integrated goal setting into our platform for patients. We ask them when they come into the program what areas they might have goals in. They might not know that they have goals, but we're going to frame it in a way that we can try to help them with that. And they can choose up to 3 of the following: living well with kidney disease, dialysis, kidney transplant and the evaluation process, finding a living donor, and living well with a kidney transplant. And we've added these particular areas for goal setting because it gives our mentors an idea of where to start conversations with their mentees. And mentors are also prompted to check off tasks in our platform, which I'll show you in a little bit, when they work on these goals with their mentees, because that initiates a customized email with resources based on that goal for mentees to then be able to have follow-up actions to work on and resources that are related to those goals that they've specified. It also lays out any kind of assisting in matching mentees that with mentors who have had experiences in those areas. So, we'll be able to match someone who found a living donor to someone who said, I want to help find a living donor. But not every mentor has had that experience or feels comfortable discussing that. So having this laid out really allows us to do an additional filter. And we do ask mentors when they apply to tell us what areas do you feel comfortable discussing with your mentees. So we ask these similarly to new mentor applicants. But those were pretty generic. Those are pretty wide open. So we do drill down to specifics because we do need to know a little bit more. Dialysis is pretty open. So what do they want to know about dialysis? Is it a dialysis access surgery, getting a fistula graft or catheter? Is it a specific dialysis modality? Do they want to know about PD? Do they want to know about home hemo? Do they want to know about, like I said before, finding a living donor, getting on the transplant wait list? Not every mentor has had a transplant. Not every mentor has been on home hemodialysis, but we're able to then find that out. That not only helps us in our matching, but also making sure that we're helping in measuring the progress that they make related to their goals that they had originally set. So once our mentors and mentees are in a mentoring connection, the mentor is instructed to review the goal topics set by the mentee, and they're instructed to check off the tasks after each interaction that they've had with their mentee, because like I mentioned, it sends follow-up emails related to the goal topic that they had gone over together. And we do have specific surveys related to each goal that go out to each mentee when they do begin that relationship with their mentor and they begin that goal-setting work. That allows us to track their goal progress and obstacles that they might encounter along the way. So as an example, you can see here some goals that the mentee has set. They're related to dialysis and transplant and the evaluation process. We have getting to know each other as something that everyone should be doing, so that's the first thing for everyone. We do want to make sure that people are establishing that rapport before they just dive right into the really meaty stuff of what the goals are. So getting to know each other, sharing a little bit about each other, setting up that rapport, making sure it is a good connection is something that we instruct everyone to do. And as you can see, as you can see, there's different tasks that are laid out, and we label them as mentee and mentor. So the mentee does not have to check anything off. Those are just automated surveys that will go out to them after they have been in the connection for a certain amount of time. So about 2 weeks after they start the connection with their mentor, they'll get a survey. How are things going? Do you need any assistance that we can provide? Have you had a call with your mentor yet? And then, how are things going? Do you feel like this is a good match for you? And similarly, the mentor will get a similar thing. So that way we can make sure it is a good match. If there's anything that we need to do on our end, we can help facilitate that. Almost everyone has had a conversation by 2 weeks. And then we have a similar survey that will go in about 30 days. How are things going? So that way we're checking in periodically and being able to make any adjustments that we might need at that point. So as you can see here, we've expanded our tasks now to the dialysis and transplant and the evaluation process and living well with a kidney transplant. So you can see that the mentor really has tasks that they need to check off. Have you set goals with your mentee and shared your experiences with them? And then checking in on the goal progress with them. So as they go through that mentoring relationship and they check off those tasks, again, the mentor is the only one who has the burden of doing this. they will trigger those automated emails that go out to the mentee after they've connected on that particular topic. So if they haven't talked about transplant yet, but they started talking about dialysis, they just wouldn't check off the transplant one yet. We want to make sure that the follow-up emails that are going out to people with those resources are related to the goals that they have already set. And we can also expand these goals. So if they were to click on any of them, the mentor, they will give them some guidance on how to approach each goal and what they might want to talk with their mentee about related to that goal. So we do give them talking points so that they're not starting from the very beginning. So we measure success in our program using a few different measures, one being a satisfaction survey and another being a pre and post program survey called the patient activation measure. I'm not sure if anyone is familiar with that tool. But I'll talk a little bit about it. I'm going to talk about the patient activation measure, or the PAM as I'll call it, first. This is a 13-question survey. Again, we administer it to them as they enroll in the program, and then every 3 months and post-relationship close. So when someone says, I'm done with this program, we can send them this as a follow-up. And as you can see here, the levels of activation are measured from 1 to 4 based on questions such as, I know what treatments are available for my health problems, and I understand my health problems and what causes them. Patients are given the prompts to answer from either strongly agree to strongly disagree. So after they finish those questions, we can score them. And someone who's at level 1 is really disengaged and overwhelmed. They lack the confidence and don't have goals. They have poor adherence. They're very passive and not really involved in their healthcare. But someone who's at level 2 is really becoming more aware, but they might still be struggling. They have more knowledge than someone who's at level 1, but they really could use more and learn more. And they can set simple goals, but they still really feel like their health is out of their control. And someone who's moved on to level 3, they really have more information. They're really building those self-management skills. They're figuring out the best behaviors for them, and they're goal-oriented. They feel like they are a part of their healthcare team, but they may still be struggling. And then someone who's at level 4 has really adopted all of these new behaviors, but they could still struggle in times of stress or change, but they are very good advocates for themselves. Again, so this is a validated tool from Insignia Health. So that survey, like I was just explaining, it really assesses self-management, knowledge, skills, and confidence, and it informs evidence-based measures of success. And our program has shown a median score, PAM score change from the initial score being 53.4 before they're connected with the mentor to 65.96 post-mentoring. And so that really signifies a transformation from awareness to actionable health management. And each point increase score correlates to a 2% decrease in hospitalization and 2% increase in medication adherence according to Insignia Health. This is a tool that is used across healthcare, not just in nephrology. So this is across the board. And upon further analysis, we found that 77% of people who completed at least one of the follow-up PAM surveys either increased their score or stayed the same from their baseline score. And again, we do provide a satisfaction survey throughout that relationship. We have an overwhelmingly positive response for those who do connect, and our survey results show that 97% of people who participate would recommend a peer mentor to someone in a similar situation, and the vast majority found their mentor to be helpful, supportive, and knowledgeable. And we also hear from our mentors who have been going through the training that they wish that they had had someone who could have mentored them when they were first going through their kidney journey. So after program participation, over half of our participants have also reported in making a change to their behavior, included changes to diet, improved blood pressure monitoring, making an appointment with a healthcare provider, or asking a clinician about home dialysis and transplant options. So like I had mentioned about that, I think I mentioned that already, but we also, ask about those behavior changes. We also ask about specific changes that are related to the goals that they set. Those are new. We just launched that in January, so don't have a ton of results yet to share with you about that, but what we have seen already is overwhelmingly positive. So we do receive a lot of feedback from the experiences of mentees with their mentors, and I've listed a few here. Peer mentoring can really make a significant impact on a patient's life. We speak to a lot of patients who don't have anyone else that they know with kidney disease, or on home dialysis, or living with a transplant. It can feel very isolating and lonely. So being able to have someone who's had those experiences can really be a big help for them. And really being able to close the gap on feeling that isolation, feeling that depression when they first come in. It can just be an additional reinforcement of the work that you do, supporting them in the decisions that they make and connecting with someone who's actually had that personal experience. And as you can see from these quotes that we have here, people really appreciate having someone to talk to that they can identify with. Doesn't make them feel bad about having kidney disease. There's no shame, there's no judgment. And that is all I have for you.
Thank you, Marissa. Actually, we'll invite the last speaker because, and we'll have a Q&A and then we'll close the session. There's been a little bit change in the program agenda. One of the speakers could not make it, so I'm delighted to bring forward the last speaker, and then we'll have a Q&A. Dr. Jonathan Haydak. So Jonathan Haydak is a PhD candidate in biomedical sciences at Icahn School of Medicine at Mount Sinai. Well, that's where I trained also, where he studied kidney disease mechanisms, particularly glomerular diseases, under Dr. Ibran Eziloglu, okay, in the Division of Nephrology. He holds an MS in chemical engineering from Georgia Tech and a dual Bachelor of Science degree in chemical engineering and mathematics from the University of Florida. Diagnosed, he's a patient also, he's diagnosed with paucine glomerulonephritis at age 22. Jonathan began peritoneal dialysis at age 23, received a kidney transplant from his sister on World Kidney Day in 2019. This lived experience fuels his research and advocacy in nephrology. A published scientist and an NIH grant recipient, he specializes in high-content imaging, multiomics, and computational modeling. Upon graduating in 2025, he plans to pursue a postdoc fellowship in nephrology with the goal of securing a tenure-track faculty position. Welcome, Jonathan.
Thank you for having me here today. I got upgraded to the last speaker. I'll try not to disappoint. As I heard that summary, I don't know about getting a tenure track position in this environment, but we'll see. So, my name is Jonathan Haydak. I'm a patient ambassador with the American Association of Kidney Patients, and I'm also actually on the board of directors. And so I've been a kidney patient for the past 9 years, and that's constituted most of my adult life. So most of my adult life has been with kidneys in the background of my mind. And later on in the presentation, I will go through or talk a little bit about my own kidney journey and the experiences had on me. And like it was said, so I originally when I started my PhD, which was around the time that I started dialysis, I was doing a chemical engineering degree at Georgia Tech. And my experience on dialysis and going through a transplant basically led me to have a career pivot where I mastered out of that program and ended up going to Sinai, where I started another PhD, basically studying kidney disease, especially glomerular diseases and podocytopathies. And so I'm actually defending my thesis on June 30th, so if anybody is a diehard podocyte fan, feel free to attend that. And so, once I graduate, I'm going to stick around for a postdoc and keep basically doing what I'm doing. And my goal here today is to provide an overview of AAKP, what we do, who we are, and what resources and services do we have to provide for you support when you are interacting with patients, when they want more information. I'm going to show some of the materials that we have. And I want to say from the start, though, that at AAKP we are huge proponents of, I'm trying not to blow up the mic. Distance, okay. All right, can we still hear me? All right, awesome. We are huge supporters of home dialysis. You know, the reality is that most of dialysis is in-center, but we're a huge proponent of trying to get that shifted so that we have more people doing home hemo or peritoneal dialysis. And so a little bit of history about us. We were formed by 6 patients in 1969, and since then we have been and will always be a patient-first and patient-led organization. And in fact, when the ESRD Act was passed in 1972, and this expanded Medicare to grant it to any kidney failure patient, one of the key drivers that really got Congress interested in this was one of the founding members and former presidents of AAKP. His name is Shep Glazer. And so what he actually did was he went in front of the House Ways and Means Committee in 1971, and as part of his testimony there, as part of kidney disease and dialysis, he dialyzed right in front of Congress. And so I think the visceral reaction of seeing somebody doing dialysis, and back in the day this would have been a huge machine, was quite strong and really motivated Congress to then eventually pass the ESRD Act. And just a side note, this event was absolutely wild. At the time, other organizations like NKF did not support it because it was pretty reckless, you know, maybe rightfully so. There wasn't an attending nephrologist there was a nephrologist fellow, and during his dialysis session, he ended up getting ventricular tachycardia. So the whole thing is absolutely wild, and if you have any interest, you should totally Google it. All right, and so we believe in high-quality kidney care driven by prevention, education, and advances in the field. And crucially, we believe that kidney care should empower patients to pursue their life aspirations and not feel limited by their disease to the greatest extent that is possible. And to achieve this, we focus on educating patients, professionals, and policymakers on kidney disease and transplantation and dialysis. We are also continually lobbying for advances in the field in these fields. And we all know that, for example, the bundled payment system for dialysis is pretty much a mess, but we're constantly encouraging Congress and CMS to improve it and work for ways to provide the newest medications for patients. And so you can see here AAKP's core principles. And if I had to really distill it down into a single statement, I'd say that we are a fully independent and patient-led organization that champions policies that improve the lives of kidney patients everywhere. And so over the years, some of the initiatives we've led are the Decade of the Kidney, which is really trying to bring the kidney to the forefront of everybody's mind. Realize it's not as sexy as the heart or the brain, but we're trying to get it there. We've launched kidney voter acts to try and bring kidney disease as an important issue to elected officials as well as those that are running for election. We have had ambassador initiatives trying to get people involved at the national and international level, and we've even had Veterans Health Initiative where we try and really highlight kidney disease in veterans and trying to get them better care. And so we are really proud to have 2 centers of excellence where we are able to help patients. And so the first shown here is the Center for Patient Engagement and Advocacy, and the second that I'll show in a second is the Center for Patient Research and Education. And so AAKP founded these centers in 2016 to serve as a rapid fulfillment hub for government, academic, and medical device manufacturers and pharmaceutical industry requests to engage kidney patient experts. The center also supports our efforts to speed the utilization of unique patient insights into unique patient insight data across both the product development life cycle and within regulatory and payment decisions, including those made by commercial insurers. And since its launch, AAKP has dramatically expanded its membership databases, social media recruitment, and analytical tools, and now services dozens of requests every year for clinical trial awareness, recruitment campaigns, patient advisory boards, technical evaluation panels, focus groups, patient surveys, clinical research, public policy research. Basically, if there's anything that you think can benefit from having patient insight or patient experts there, AAKP is probably somewhere nearby. And so AAKP leaders and staff, we provide expert advice to organizations and companies on how to work meaningfully with patients as co-investigators and partners, and offer online training for patients on how to be equally effective collaborators. And I'll talk about that more in a little bit. And so this was the Center for Patient Engagement. We also have our research and education. And so one of the things that we've done a lot is getting clinical trial awareness. So one of the things clinical trials is it can be challenging to recruit, especially when you have targets. So for example, now that we have all these new medications, as SGLT2 inhibitors become the standard of care in CKD, a lot of companies, when they do clinical trials, they're trying to recruit a subset of patients that are diabetic, that are not diabetic, that are on a GLP-1 agonist, that aren't, and so it can be difficult. And so AAKP is there to launch awareness campaigns to try and get the word out to the community and basically help. We think that the more research there is, the better. And like I said, overall, we love home dialysis as a modality option. We feel that as far as dialysis goes, home dialysis aligns best with our core mission of getting kidney patients the best treatment possible to give them the best life that they can. And we provide, through our materials, trusted, unbiased, patient-centered education on all treatment options. We really want patients to choose a modality that aligns with their values, like was said earlier. And we really support an individual's right to change their treatment. Really, what this comes down to is we want to get as many people out of in-center dialysis and at home. And likewise, we advocate for increased awareness, care choice, and access to home dialysis therapies. It can be hard. And yeah, especially in today's advocate for increased research and innovation. I don't know how that's going to go, but we were doing okay for a while. And we have a lot of resources here. And so this is you can see a screenshot here of our sample materials. But we have introduction to all dialysis modalities and access options, pros and cons for home dialysis therapies, questions for patients to ask their team, patient stories and video spotlights, as well as a bunch of different webinars ranging from a bunch of different topics in nephrology. And the thing with all of these materials is that they are made by patients for patients. And so this is another example. These are little booklets that we have you can find online for understanding home hemodialysis options as well as peritoneal dialysis options. And then these are for choosing the right therapy, and then the one on the right is for really trying to get people that want to get off in-center hemodialysis and to a home modality. Right, and so a little bit about my journey. Why am I qualified to be up here talking about home dialysis? So on this chart on the bottom here on the y-axis is my quality of life or my happiness, and then on the x-axis is time. And so when I was 22 and I thought I was invincible, one day my feet got really swollen. I remember Googling this at the time, and Google said either your heart is failing or your kidney is failing. And it turns out this was one of those weird cases where Google tells you you're dying and you actually are dying. So I went to the doctors. I had some basic lab work done. I was spilling a ton of protein in my urine, grams, I think like over 5 grams, and my creatinine was 3.5. So whereas I just thought I had some minor bloating issues going on, it turns out I was full-blown nephrotic. So I got referred to a nephrologist, and as soon as I saw him, he basically said, okay, after this appointment, you're going to go out there and then go check yourself into the hospital. And so I ended up being started on a really aggressive course of high-dose steroids and cyclophosphamide. And it was moderately successful in delaying the immediate need for dialysis. So it kept me off of dialysis for about a year. And so there's pictures of me there in the hospital, as well as me in the infusion center. You can really see the dramatic difference, all the bloating from the prednisone. But ultimately, around the time I started my PhD at Georgia Tech, I ended up starting peritoneal dialysis. And so then I would travel everywhere with my machine when I was on PD. It was, it was cumbersome, but I would do it. I could load up my little PD device and then travel, bring a ton of bags. One of the interesting things about PD that everybody here is probably aware of is the amount of space that it takes up, which really poses a unique problem for a place like New York City, because personally, and my wife gets mad when I say this, but my wife and I and our 3 cats, we live in a closet. And so if I were to have to restart dialysis now, I don't really know how I would manage the space requirements. And I know some clinics try and get around this. They try and do more frequent deliveries, like every week or bi-weekly. But one of the toughest challenges of, I think, especially in large urban areas, and definitely New York City, is the space for all these supplies. And then, like it's been talked about before, if you're doing home hemo, you have to make sure that the plumbing is right, that the building is right, that everything is right. So it's a little bit more challenging, and all of these barriers, I think when you're a patient there weighing your options and you hear that there's all of these issues that you have to overcome, I mean, even if they are overcoming, the more barriers you are, the less patients are going to choose that option. So I think a really dramatic emphasis on the importance of home hemodialysis and the better outcomes is what we need. And I think we're doing better as a field. We just need to keep pushing it. Okay, and so returning to my story, I was still pretty okay when I started peritoneal dialysis. I still had some residual renal function, so I was urinating. So I could be pretty liberal with my diet and fluid intake. And then eventually I lost it, and this was the point where dialysis became really rough for me. And then on top of that, I actually experienced over this time, my PD catheter failed. So then I had to switch to in-center hemodialysis for about 6-ish months. I got a new PD catheter. I went back on PD, but just my entire time, like about 2.5 years on dialysis, was really, at times it was a bit soul-crushing. But having done the 2 modalities, I can say that by far the home peritoneal dialysis was much better for me than the in-center. Just the waits between sessions, you would accumulate so much fluid. I felt much better on peritoneal dialysis. Okay. And so then eventually in 2019, I got a transplant from my sister, and she's pictured there along with me. And one of the most dramatic things after I got the transplant is I started diuresing so much with the new kidney that I lost, I don't know how many liters, but I actually got like a face again, so it was quite nice. And so another key point I want to make is that patients can be more than just participants in research or clinical trials or whatever you're studying. They can be really powerful partners. And so I'm going to highlight this with 2 articles that I've written. The first one here, my co-first author, Jacob Wright, or Jake, he is also in the same lab as me at Sinai, but he is also a kidney transplant recipient. He had FSGS. I told him I was sharing all this information. So he had FSGS. Very interestingly, he found out he had the APOL1 gene by doing 23andMe. So prior to that, his diagnosis has been this weird like strep throat infection, FSGS thing, but it turns out that was completely wrong. So we wrote this article, and the point of it was that there's a lot of power, and it's really an unexpected boon to have patients with lived experience taking part of the research process. And so, for example, in our lab, we are working on a vascular access device for hemodialysis, and so this is a little piece that sits over the fistula, and it's supposed to make cannulation much easier, and it also prevents bleeding after the needle is removed. And so Jake, he also has a background in engineering. So I look at this and I think, wow, I mean, who is better to integrate the design principles of this than somebody with the lived patient experience? And so I think he is in a truly unique position where he can do what very few people are able to do. And then the second article down here, this was a patient voice in CJSON. Basically, my point here was that in a lot of the outcomes for trials or studies, it's usually based on lab work and numbers, and I think that's starting to shift, but when I was on PD, I didn't necessarily care about my phosphorus levels every visit. I know that I cared about my quality of life. How was I enjoying life? The thing is, I know the two are related, but there's so much emphasis on just what is your phosphorus level, what's your potassium, what's your fluid levels, and there's very little, I think, consideration into what is your quality of life, how can we best get you there, even if it means not being a little lax with certain things. And I know it's a tough thing to balance, but I think I'm at least advocating that there's a more holistic picture. And then finally, the last example I've had is the Kidney Precision Medicine Project, or KPMP. And if you haven't heard about it, it's an ambitious multi-center consortia, and this is led by Jonathan Himmelfarb at Sinai and Matthias Kretzler at Michigan. And this is really aiming to use very precious human kidney tissue obtained from biopsies. This is the first study to actually do research-based biopsies that are not for diagnostic purposes. And we've had some amazing findings with that, just absolutely fascinating. But so we get tissue from healthy reference CKD and AKI patients, and then we combine this with the latest molecular interrogation techniques to really get human kidney disease at a scale and resolution that hasn't been achieved before, and especially in humans. And one of the parts about KPMP is they are very big on the patient part of it. So I am both there as a researcher, but also as a patient partner in the Community Engagement Committee. And so for example, there have been patient-led publications that have come out of this, and they really go with the approach that patients are essential for their success, and that having the patients there grounds them in their mission, that this is all to better patients, as well as at every meeting, one of their favorite parts is there's a patient panel where everybody there gets to hear from the patients and study participants as well. Right. And so that's really all I have to say. And in conclusion, I hope that I have convinced you that at least some of these patient organizations, they can help you lead to better outcomes with your patients by providing material, resources, whatever it may be. This is just a plug for AAKP. Here's our social media. We have a special offer going on today. If you want to join us, there's a discount. And yeah. Thank you very much.
Thank you, Jonathan. That was really wonderful. And so I'd like to invite the speakers, Dr. Gupta, Marissa. Please come up, and actually I want to ask a couple of questions to the panelists. The question I have is actually to both Marissa and Dr. Gupta. What sort of patient mix population are you seeing, Dr. Gupta, in your home hemo? Is it more African American? Is it more Latino? Is it more Caucasian? And then question to Marissa after that is, what sort of people are contacting your peer support? Is it really mainly Caucasian population? Is it African American? Or, is there population that are reserved and don't want to contact you? Got Dr. Gupta first.
So my home unit is in Bronx, and the Bronx population is similar to, I think, Brooklyn, like more or less. So for us, home hemodialysis, we actually have good percentage of Hispanics and African Americans on home hemodialysis. So we have noticed that, recently we have started like direct to home. So we have increased our patients directly taking from, when they're discharged from the hospital. And even if they are not the right candidate, we try to just give them education, just few sessions at our home unit, and then they can just transition to in-center if this is something they don't like. But with this, because our in-center is just below the home dialysis unit, so it's in the same building.
So do you have about 20% African American, 30% in terms of percentages?
So in percentage, I would say, yeah, at least 20 to 30% Hispanic and 20 to 30 African Americans.
Okay, thank you. And Marissa?
So yes, actually I should have included that. I was just doing some reporting for our annual update, and I was looking at kind of the breakdown, and we do have people self-report, and it looks like over 60% of the participants identify as white or Caucasian. And then I believe we have a mix of the next highest population in our program is Hispanic or Latino, and then African American, and then mixed race. So we have a breakdown, but again, we're across the country. So one of the things that we do try to make sure that we do is have a mentor pool that is representative, to make sure that if people do say, I want to talk to someone of a particular race, we can try to honor that request as well.
Thank you. And Jonathan, the same question applies to you. I mean, in your organization is absolutely fabulous, I think, and the work you did with partnering for research, and because I was reading about it, and it's really phenomenal. You rejuvenated, your organization rejuvenated patient enrollment and really finding answers to tough questions and diseases. What sort of, do you know how many of the members are really, again, the same question, African American, or, how many are truly members that reach out to you?
Yeah, that is a great question on both accounts. I don't know the numbers offhand. I will say that at least the leadership right now of AAKP is heavily Caucasian, white. The membership is more diverse, so maybe that's a problem. One of the related point, though, is when we deal with clinical trials, especially internationally, with companies that are doing sites all over the world at the same time, one of the things that we repeatedly try to make the point to them is that the United States is a melting pot. And so when you're choosing centers as to where you want to run your trials, that you should really think about the demographics of the people there. And even in some studies, I'm on a DSMB member where basically our comment to them is, you don't have enough Hispanics. We need more. And so it's the same thing with clinical trials. You can't just run them in cities that aren't representative of the makeup of the United States. I mean, we know that the genetic background will interact with drugs. And so if you want to answer the question, is this a benefit to patients in the United States, you need to make sure that the people you are testing it on are a representative demographic, it's inclusive, and that everybody is accounted for.
Thank you.
I have a question. In terms of peer mentoring, do people actually have to belong to AAKP or NKF to actually get a mentor from there? If they're
Not for NKF, no, absolutely not. Anyone can join membership. We don't ask anything about that, no.
Yeah, it's the same for AAKP.
Okay, so my question, I guess it's geared towards you, Marissa. The information that your mentors are providing to the mentees, is it information that you train them in prior to them getting a mentee? And is that information something that's available to, like, say, social workers, especially, after hearing this morning that this motivational interviewing is a way to go? I'm thinking that after looking at some of your topics, it's information that we can have our social workers use in a motivational interview methodology with our patients.
So we don't have them necessarily, we're not educating patients and then having them instruct their mentees. Really, the emphasis is on sharing their personal experiences. If they're struggling, if the mentee says, I'm struggling with taking my binders, my diet, my potassium, like, we know that's a common thing. We're not teaching the mentors to talk about how to manage your phosphorus. What we're telling the mentors as we're training them is how to use their experiences and not give medical advice, because we don't want people, saying, well, this is how many binders you should take and this is when you should take them, because that's really for their medical team, but to really harness their own stories and share, here's how I went through this, not telling people what to do, but saying, here's what worked for me. Do you think that might work for you? Empowering them to go back to their team with those kinds of questions, because we want people to feel like they have that positive relationship with their healthcare provider. They know where to go for that specific information for their own health. But for the mentors and those topics, it's really to harness their personal experiences with those topics, which is why we ask the mentors, what do you feel comfortable with discussing with your mentees? Because we also don't want people to feel like, well, I didn't have experience with this. Why did you match me with this person who wants to know about that, right? Because if you haven't had that experience, how are you supposed to share about that? I hope that answers your question a little bit.
So I have, does that?
There's a question in the chat,
Go ahead.
and this is for Dr. Gupta. Dr. Gupta, do you think that these prescription modules need to be in the training fellowship programs?
So we made this website taking that in account, and we have been reaching out to different, fellowship programs, and we are letting them know to expose, to let their fellows know. I think this is very useful for fellows.
And there's one more question. How do fellows get trained for home hemodialysis?
So in our program, we dedicate specialized blocks for them to train in home hemodialysis. We allot them patients and a mentor throughout their training program, and they have a curriculum, home dialysis curriculum that they follow, and they go through each and every training. They spend some time with home hemodialysis nurses, with technicians setting up the machine, social worker, they attend our quality meetings. So we are trying to give them more exposure as possible.
And there's one last question about the flow fraction. Basically, if the dialysate flow is so low, how do you get adequate KT/Vs?
So that's what, so the dialysate flow is low, and the flow fraction, so depending upon what is the flow fraction, if it is low, then it ensures that, the dialysate is getting more saturated with urea. So it's just the different in mechanism as compared to in-center. But we are able to, so because we don't follow the same standard KT/V as an in-center, it is translated into, single pool KT/V.
I think that's
I
it
have
for
a
the chat.
follow-up on one question to Jonathan and then to Dr. Gupta. Jonathan, can you tell me in your journey that I noticed, transplant never came in till much later. Why was that?
Okay, so this is kind of me being an idiot. When I first started dialysis, like right before, I was like, you know what, I'm gonna suck it up, I'm gonna do it, I don't need nobody's kidney, I'll wait for one. Then about a year in, I was like, wow, my life is kind of not good. And then my uncle, because my sister had talked to and she wanted to, my uncle, who is a really cranky old man, he like really chewed me out. And so that was a very profound experience to me and really made me open to it. And so then there was, my sister's in New York, so I had to move to New York. I got worked up near her. So it was a combination of me being stubborn, trying to figure out if I wanted to stick around in school for my PhD, but ultimately I made the right choice. I took the kidney.
Yeah, so in hindsight, Jonathan, do you believe, I showed you the data, what we have, preemptive close to decimal statistics. Should we reverse, that should be number one, right?
Oh yeah, I think if that had happened, I wouldn't have the heart problems that I do. I wouldn't have the left ventricular hypertrophy. I'd be much better off.
Right. And Dr. Gupta, I sort of had a follow-up question to your training period, the block schedule. Is it a month? Is it 2 months? Is it in the first year? Is it in the second year of the training? When do the fellows, can you give us some insight?
Yeah, so for the first year, we don't have a lot of elective time. So this is one of the elective, but this is a mandatory home training elective that
It's an
we have
elective, so it's not mandated.
made. No, it is like we utilize it in the elective block because,
Okay.
so in the first year, they just have 4 weeks of elective block, so only 2 weeks it is home training, but in those 2 weeks, they have 2.5 days that they have to spend in the home clinic. But it is more in the second year, because in second year in our fellowship program, they have more time for research and more elective block. So in second year, they have mandatory 4 weeks of home dialysis.
Okay.
And every month they rotate, or every month they follow their own patients. So that also, just follow up and seeing the complications and how things change over time, that is also important part.
Right, so I think with the CKD education, I mean, we heard Dr. Bailey talk about preventative and all, but the story of Jonathan is very unfortunate, right? I mean, I think his diet is very good and all, but so there are diseases that affect individuals that they don't have a choice. Am I correct, Jonathan, right? So we do have to encourage transplantation, I think, number one, and Marissa, you can comment on that. I mean, when a lost patient calls you, I mean, do you steer them towards more transplant, or how does this work? Do you steer them towards a mentor who has received a transplant? So I think that's what is needed right there.
Yeah, we certainly have, we try to really meet the person where they're at. So if someone calls us, they're totally lost, we really try to level set, where are you in your journey? What do you need to know? We can spend half an hour, 45 minutes on the phone with the person if it's really, they're very overwhelmed, and try to give them that basic education. We do a lot of follow-up afterwards with making sure that they have, when they're going to have more questions, where should they go? Sending them some psychosocial education on treatment options. We have free online courses that they can take, all of that, but then certainly connecting them with a mentor who has had a transplant. We have a lot of mentors who have had transplants, so I think giving them that information, if they do want to learn about dialysis and transplant, a lot of our mentors have both of those experiences, so they can speak to multiple things. So I think at that point, once they've kind of feel more comfortable after that first conversation with someone at NKF, when they come to us saying, I need some help, we kind of lay out all the options for them, and then we say, do you want to talk to someone who's been through that before? And that is really where those powerful conversations come through.
Thank you. Errol?
Yeah, this question is for Jonathan. I mean, you mentioned the difficulties that the patients face in home when they have to deal with all of that supplies, all those supplies that they get. Even though you mentioned that, we've tried different things like, more frequent deliveries and so forth. Did you come up with any other insight of things that we might be able to do that can alleviate that problem somewhat?
Oh no, it's so hard. I mean, especially in New York City, not only that, but you have some people that are, they don't have a home. What are you going to do with them? That was touched on briefly. It's just really challenging. I don't know, it should, my gut feeling is if you had some sort of money pool to help them, you would end up saving money in the long term, but I'm not naive enough to think that that's ever going to happen.
I have one last, if there's no more questions, Dr. Gupta, I mean, what sort of access care do you provide to your home hemo patient? How often do they go to the access center, et cetera? How often do they look at the fistula? Is there any protocol you have?
So we don't have particular protocol. If they have any problem with the fistula, then they go early on, but on an average, 3 months.
Every 3 months.
Yeah.
This is exactly what we do also.
Okay.
And just as a side note, Errol's question, I've looked at I think I mentioned average square feet area with population density in New York, and apropos to what Jonathan was saying, actually I presented at Sinai about a few years ago on home, and I told them this space is going to be a constraint. I made them, I alerted them way ahead of time. Well, some people picked up on it and said, yes. So I think it's going to be a challenge. But if there's no more questions, there is a question in the back.
Hello. I just have a question. I have like a couple patients with HHD, and when I'm assessing the KT over V, sometimes I get like a 4 or a 6, and I'm just not sure how to tell like over time if their urine residual is going down or like what numbers to look at when the KT over V should be 2, and then sometimes like, their KT over V, is over 6.
So this is for the home hemodialysis?
Yes.
Yeah, so, it means that you can liberalize, and if they have residual renal function, that can be taken into account while we are making the prescription for them.
So when I'm-
I think we do go by KT over V, but overall, it's the overall picture of the patient, how much is the interdialytic weight gain, whether they are hypertensive, their phosphorus levels, how they are feeling, their symptoms. So I think for prescription, we need to look as a whole patient instead of just focusing more on KT over V and taking, patients' values and what they want, their lifestyle choices into account while making our prescription.
Okay, thank you.
So just one last point, Jonathan, you're actually in my lifetime second patient who's had a double PhD. When I was at Sinai, there was one patient who had a double PhD. So I don't know whether he's still alive, but this is, going back to the 1980s, and so congratulations for your tenacity. So with that, we'll close, and thank you, the speakers, and thank you, everybody. There's will be CME credits given, so not to worry who attended it, who wanted those, but thank you. And I'm thankful to all my speakers and all the attendees. Thank you.